Hello, everyone. I'm Dr. Darrell Regal, clinical professor at NYU, and with me for tonight's program is one of the world's experts in inflammatory skin diseases, Dr. Mark Lebwohl, who will present on an issue that faces all of us, an update on managing your biologics patients during COVID-19. First, we'd like to thank you for joining the over 2,000 of our colleagues for tonight's program. We would also like to thank those who continue to support dermatologic education: Lilly, Dermatologics, Sanofi Regeneron, Sun, UCB, Novartis, and AbbVie. And for the collaboration on tonight's program, we thank the National Psoriasis Foundation. Last week's program had over 2,000 live viewers and an additional 1,200 on-demand views at the fallclinical.health website in the past few days. More importantly, over 200 questions were submitted last week from the audience. So as a follow-up to last week, the Fall Clinical course directors have organized tonight's program as an update and to try to provide needed guidance on this critical subject to enhance patient care. We strongly encourage your questions, which can be submitted at any time, by clicking on the Ask a Question bubble on the lower right hand of your screen. Questions will be answered after the formal presentation. So now, for the next 35 minutes, let's hear an update from our colleague, Dr. Mark Lebwohl.
Good evening. My name is Mark Lebwohl. I'm chairman of the Department of Dermatology at Mount Sinai, and delighted to be here for our second weekly webinar on coronavirus and the impact on dermatology. So we are going to launch right into this. And after the last webinar we had literally 200 questions that we didn't get to. So we're going to continue with answering many of the questions that were asked, but we're also going to give you a little background now that we are heavily into this pandemic in New York. It's having a tremendous impact on the way we practice and teaching us ways on which we manage our staff, manage patients who come in, what happens if, relatives are impacted with the COVID-19 virus. Does that have an implication for the people who they live with who come into our offices? And of course, the answer to all that is yes. And we'll go over as much of that as we can in the next hour. Now, I'm going to say again, if you want to submit questions, we will have plenty of time for more questions at the end. Click the chat icon on the lower right side of the video player, type in your question and submit. And you can do it any time during the webinar. You don't have to wait till the end, and we will answer them at the end. So let me start out with a question that I have gotten over and over again repeatedly, and I really liked the comment that was made by the questioner here. Many of our patients are holding their injections because they're getting mixed messages from their physicians. This is crazy. A few weeks ago, we would have never considered patients on IL-17 or IL-23 blockers to be immunosuppressed. The hysteria around COVID-19 has made us think irrationally. And I will agree that, this is a serious epidemic, mostly because it's very contagious, so a high proportion of Americans will get it. And even though the death rate is low, and it's probably somewhere on the order of between 0.5 and 1%, we are not prepared to have 1% of Americans, hospitalized. We are simply not equipped as a nation for that. So that's why there is some hysteria, and we are better thinking about all this rationally. So in the last week, 2 of our major organizations have come out with guidelines. Probably others have as well, but I particularly like these 2. And this is from the National Psoriasis Foundation Medical Board, and they do not recommend that all patients stop biologic therapy. On the other hand, if you are actively infected, you should stop whatever biologic you're on. And as for specific cases, and I have to say, every single case should be dealt with on a case-by-case basis because different people are different. I gave examples of that during the last webinar. I'm going to give a couple of them this evening. But high-risk groups, and we'll define what those are those patients need to have a serious conversation with their healthcare provider. Those are the patients, whether they're on a biologic or not, who should probably be self-isolating, self-quarantining, really trying everything they can to avoid catching this virus, because those are the groups of patients who are truly the ones who are likeliest to fall into that 1%, 0.5 to 1%. And so every patient-specific situation concerns should be taken into account. The AAD also had a very good guideline. There is insufficient evidence to recommend discontinuation of biologics at this time, same as the Psoriasis Foundation, and they should discuss the risk versus benefits for every patient. If someone actively has COVID-19 infection, they should discontinue or postpone their biologic therapy. And again, in high-risk individuals, have a conversation with your physician. Consider deferring initiation of biologic therapy if you're not on one already. Now, this came from the Harvard Medical School health letter, and I just want to go over the symptoms of COVID-19. The symptom that was present in almost all patients who are not asymptomatic, and there are many asymptomatic individuals, are either patients feel a fever or they have a low-grade fever. And that symptom is one that we check for a lot if we suspect the diagnosis. One of the early symptoms is a dry cough. Patients get flu-like muscle aches and joint aches, so myalgias and arthralgias. A headache happens in a percentage of patients, and sore throat happens in a percentage of patients. Those are considered mild. These are the patients we send home with self-quarantine. The Harvard Medical School letter says 14 days. I'm going to show you the guideline that we use at Mount Sinai in New York. In terms of patients who have moderate disease, now here's where you get more serious, and here's where perhaps the patient, you should consider sending the patient in to a place that is a COVID-19 testing center. And they will test the patient, and they'll also assess the patient and see if they think the patient needs hospitalization. When the patients have high fever or are short of breath, they need to go to an ER. Actually, at Mount Sinai, our ER is the testing center. We did convert one of our other facilities to a testing center, but I think we are headed in the direction of moving everything to the ER. If the patient has any trouble breathing, then they simply need to go to an ER. And right off the bat, somebody who who's on oxygen, if you suspect COVID-19, that would be a patient with whom you need to have a conversation with their physician and potentially going for testing. Shaking chills on this list is also considered moderate disease, and profound fatigue also considered moderate disease. And here, basically, we isolate patients, we give them supportive care, and we'll go over some of that in the course of the next few minutes. If patients are severely short of breath, you've waited too long. Those patients need to get in. Here are the patients who you really are running a risk of getting in trouble. Now, you're going to hear about the number of risk factors, and anyone with heart disease, hypertension, and here they say that might be because of ACE inhibitors or angiotensin receptor blockers. We'll talk about that a little bit because that is unproven, but among the patients who died in the Wuhan province outbreak, hypertension was a risk factor. Diabetes was a risk factor, and of course anyone with a chronic pulmonary disease like asthma or emphysema should be considered at high risk. Patient with a cancer that is not cured, and of course, if somebody has a basal cell, I probably wouldn't put them in this category. But if somebody has metastatic melanoma, they would be in this category. Patients over the age of 60, I never considered over the age of 60 elderly, but they are considered as being at higher risk, and anyone who is immunocompromised. We're going to talk also about ibuprofen and whether there's good evidence for that. So this is a question that I got from one of our MAs, and she actually, this is a PA, physician assistant, who's managing bullous pemphigoid patients on high doses of prednisone. And someone on the PA Derm Facebook asked, shouldn't we switch them to dapsone? So here's the dilemma with bullous pemphigoid. Bullous pemphigoid is a life-threatening condition. It is not only miserable, it is dangerous. And before we had systemic steroids, patients often died of bullous pemphigoid. Having said that, clearly systemic steroids are immunosuppressive, and of course we would like to get patients off them as quickly as possible. And, when I discuss this with the PA, I say, I don't treat high-dose prednisone patients any differently today in the era of COVID virus than I did before. I always tried to get them off their prednisone as quickly as possible. The drugs that we would go to would be Cellcept, and that, of course, is immunosuppressive. Dapsone is a possibility, and if you have a neutrophil-rich biopsy, when you biopsy pemphigoid, that might predict a response to dapsone. The problem with dapsone is the patient is going to have to get blood tests frequently. The first month on dapsone, you're supposed to get blood tests every week. So now you could send a visiting nurse to the patient, but again, that's an external exposure for that patient. Or the patient can come in and be tested. So, dapsone's not a bad thought, but don't fool yourself. It's not that benign a drug, but also you can't just put a patient on dapsone and drop their prednisone. You're going to be tapering prednisone. Many of these patients have been on it for months. You're going to be tapering it over months. So you're not going to get them off it in a week. So that patient is really in a group of patients who are at risk. Same with Cellcept patients. And my instructions to those patients have been, you have to isolate yourself and protect yourself against external exposures better than anybody else. Those are the patients that need to simply, park themselves at home. Often they're with a spouse or a partner, and they should be at home with that individual and virtually never leave. Anything that comes in from the outside has to be clearly free or disinfected, free of COVID-19 or disinfected. So those patients are difficult. Now, I will say there are some other drugs that come into play here. IVIG is probably pretty safe, but I know that many infusion centers have closed because many hospitals are preparing to open every space they have for hospitalized COVID-19 patients. And I know that in New York, we are very worried. We are short of beds, and we're worried that in a couple of weeks, we won't have room for patients who we need to take care of. So it's hard to get IVIG now. The other thing is, if something is even remotely elective, we're short on masks, we're short on gowns, we're short on gloves. And so we don't want to be using those materials for patients who you might be able to delay. So IVIG would be a good solution here. The other potential solution, of course, is rituximab. And again, we're not doing a lot of rituximab today, but let's say that we could. In general, I think rituximab has proven safer than prednisone and other immunosuppressive agents for pemphigoid. But it is very clearly is a risk factor for getting rare viral infections. And the question is, does that mean it's a risk factor for getting coronavirus? And the answer is it probably is. The dilemma with rituximab is you need B cells to form antibodies. And, my prediction is that when we do have a treatment that actually prevents the disease, it's going to be a vaccine, and antibody formation is going to be critical. So rituximab may be an issue. This is a difficult group of patients, but you can't just take a patient off of prednisone. So the patient has to use a lot of protective effort and come off the prednisone gradually. Now, there's been a lot in the news about hydroxychloroquine, which is Plaquenil. And how did this come about? Well, there was an article from France where they treated a small number of patients with hydroxychloroquine and azithromycin, and their endpoint was clearance of the virus on culture. by day 6. And as you look here, the patients on hydroxychloroquine are the red line. The patients not on hydroxychloroquine are the black line. And you can see that days into it, the patients on the black line are still shedding the virus. The patients on hydroxychloroquine, most have stopped shedding the virus by day 6. So this is a very small number of patients, but clearly looks like a win for hydroxychloroquine. In the next graph, they also separately looked at patients who were taking both azithromycin and hydroxychloroquine, and that is the green line. And what you see here is that at day 5, the shedding of the virus is gone in the group that's on a Z-Pak along with hydroxychloroquine. By the way, the dose of hydroxychloroquine in this study was 200 milligrams 3 times a day. This has, I have to say, led to a national shortage of hydroxychloroquine, and the nation's pharmaceutical companies are gearing up to make as much of this as possible, as quickly as possible. But apparently there's panic buying of this all around the globe. This prompted the University of Miami to do 2 things. One of them is they say, here are the medicines that we think might be helpful. Hydroxychloroquine, which appears to be a little more helpful than chloroquine, and tocilizumab. Here they said sent out this list and said, please don't buy this list so that we have enough medication for sick patients. And what did everyone go out and do? Of course, they went out and bought hydroxychloroquine. So hence there is a shortage. There are some other drugs with some evidence that they are beneficial. One of them is baricitinib. One of the known regulators of how COVID-19 gets into the lungs and then into the body is by endocytosis through a protein that's AP2-associated protein kinase called AAK1. And the thinking here is that if you disrupt AAK1, you can interrupt the passage of the virus. And in fact, baricitinib, which is a JAK inhibitor, either as 2 milligrams or 4 milligrams once daily, is sufficient to inhibit AAK1. Now, this is completely speculative. I will say JAK inhibitors, including baricitinib, have been used to treat psoriasis, and they work. And they work reasonably well. But again, that's very speculative. We don't know it's protective against coronavirus, but just be aware that that is one of the drugs that's been implicated. Also, I thought you'd find this interesting. An inhaled corticosteroid, cyclesinide, which is used for asthma, blocks coronavirus replication. And so this is, again, one of the articles coming out of the Chinese epidemic. They also report that mometasone does the same thing. So mometasone spray inhibits replication of the virus. I don't know if other steroids do, but they might. A lot has been written about ibuprofen specifically, but NSAIDs in general in COVID-19 infection as being a risk factor for a worse outcome. And that was based on at least the first publication I saw was, I believe, 4 patients who died had been on ibuprofen. And I think the evidence on that small number of patients is simply not enough to implicate the whole class of drugs, yet many of our patients are stopping NSAIDs in general, and specifically ibuprofen. And Dr. Gladman, who's a former chair of dermatology at the University of Toronto and a very well-known dermatologist, particularly in psoriatic arthritis, said it's not clear that NSAIDs are the culprits, and she does not recommend stopping anything. And having active disease may be worse than getting COVID-19 for many patients. So I think that's simply an unanswered question. Sorry, not COVID-19, just a dry throat. Here's what the Department of Health, New York State Department of Health says, and I'm going to show this slide a couple of other times to go to points. Basically, there's no reliable data that use of NSAIDs or ACE inhibitors, another drug class that's been implicated in worse outcomes. There's no evidence that either of those is harmful. So I will say, many of our colleagues are discontinuing them or switching to alternatives. Tylenol certainly does not have the same problem that ibuprofen does, but there's no evidence that ibuprofen makes it worse. Okay, now let's get down to some practical things that are going to come up in your offices. So here's one question. A patient was seen in our office, was diagnosed the same day with COVID-19. Do we have to test everyone in the office? So first of all, there's a very straightforward guideline as to what you do. You're not supposed to test everyone. Since you've all been exposed, and let me tell this world of dermatologists, we are all going to be exposed. So you may as well start doing this now. Start wearing masks all day, every day. You need to wear it if you're going to your offices. Assume that you've been exposed by the patients who come into the office. For specifically that office staff, it is worthwhile for patients who are close to and spend any time with the patient, checking their temperature twice a day to self-monitor for symptoms of COVID-19. So again, if someone is exposed for any amount of time within that 6 feet social distance for several minutes, they probably should be self-monitoring, but they can come to the office. And we'll talk about what happens if they have symptoms then. But until they develop any respiratory tract symptoms or fever, we assume they don't have it, but we assume that they might be at risk for it, and therefore we have them, mask, glove, whatever personal protective equipment you have in the office should be used on them. Now, this again is from the Department of Health. There is a shortage of material to test these patients. So outpacing patient testing must not be encouraged, promoted, or advertised. So let me bring this down to the individual dermatologist's office. As a rule, we should not be testing under the circumstance I just showed you. Where could you go wrong? If someone becomes symptomatic, and even then, we're not supposed to test, we're supposed to send them home. But if someone becomes symptomatic and you did take a test and the test came out negative, you would feel better about them returning to work in a shorter period of time, and we can go over that later. But the bottom line is, in general, we're discouraged from testing the people in our office. If somebody has any symptoms, they should stay home. We are not changing that management, whether they test positive or negative. If they're mildly affected, they should stay home and act as if they have it. There is a national shortage of personal protective equipment, and there is no reason that we should be testing either asymptomatic people or mildly ill people who are not hospitalized. We are saving the tests for patients who are hospitalized. We do not want to mistake a MRSA pneumonia for a COVID-19 pneumonia because that is treated very differently. So whether the patient's a first responder, a healthcare worker, an office staff member, we right now do not test them. All right, the same line of thought, our medical assistant has a cough, sore throat, and running nose. Should we test her? What should we do? Pardon the punctuation, these are not my questions. Again, if office staff have mild symptoms, send them home. We don't test them. Everyone in the office who presumably was exposed to that individual should now wear masks and self-monitor with temperature checks twice daily and be on the lookout for respiratory tract symptoms. When do you stop self-isolation? So I showed you the Harvard medical letter said 14 days. That's not the policy at Mount Sinai. And by the way, if you Google Mount Sinai coronavirus, there's a website with very good information about what to do. If you go to Fall Clinical Derm, fallclinicalderm.com, we also have very good pieces of information. That includes scripts you can read to patients. It includes what you do under circumstances like this. So there's a lot of already established and based on an experience in New York City for how you should manage this around the country. You can stop self-isolation when three things happen. One is you haven't had a fever for at least 3 days. Two, your respiratory symptoms are improving and almost gone. If somebody is still coughing or sneezing, we don't want them in. If those symptoms are gone, but they may still have a raspy voice or something like that, sure, they are allowed to come back. And the most important one is at least 7 days have passed since your illness has started. So any of the three of those, and at least the instructions here at Mount Sinai is that you can stop self-isolating. What about a physician or staff member who was tested positive for COVID-19 and they work in an outpatient practice? So first of all, there's some things you have to do, and if you don't do them, you are responsible for spreading this virus. Whoever is in charge of your building, and I'm at Mount Sinai, so we end up notifying infection control, and they notify housekeeping, who intensively disinfect our practice. So whoever is watching out for your practice in terms of cleanliness should be disinfecting the practice. There are several agents that are useful. Certainly alcohol is a potent disinfectant. Even hydrogen peroxide is a disinfectant. Here at Mount Sinai, we have the luxury of calling on infection control. Whoever is the medical lead in the practice might want to reach out to an infectious disease doctor, describe how they interact with patients, and decide which patients they're going to inform, because you will be responsible for letting patients know. Otherwise, we're spreading this disease. So if a person in your office staff or the doctor himself tests positive, if you go to those websites I mentioned, there are scripts for what you can say to patients to minimize the spread of disease. Those patients need to act just like your office staff did. They need to, wear masks, self-monitor to make sure they don't get the infection. Okay, in patients who've been tested but are awaiting their results, and let me say very quickly, if you came to Mount Sinai and you were on our staff, we would try to get you tested here at Mount Sinai. We can get the result within 12 hours. If we send it out to LabCorp, it could take as much as 5 days. And it's not LabCorp's fault. They are inundated with specimens. So they simply can't get to them. Until you get that result, self-isolate, be especially cautious if there are elderly people with significant medical issues when you're self-isolating, and do not handle pets or other animals when you're sick. So, protect older or immunosuppressed people from you, and don't handle pets or other animals. Okay, here's a good one. A patient arrived at the office complaining of a severe rash. He has an obvious bad cold, coughing, and sneezing. Should I see him? I actually this is the question that came in, and I wanted to switch this to my mother-in-law arrived at the office complaining of a severe rash. You have to treat patients, as best you can. But I will say that at Mount Sinai, on the first floor of this building, there are guards that examine patients when they come in and ask them, do you have any running nose, cough, fever, sore throat? If the answer is yes, they ask them to leave. They ask them to go to the COVID testing center down a couple of blocks down. If the answer is no, or the patients are just pushy enough to get in, then they end up on our floor. And that's uncommon. We have not seen a single patient since this started who's had a cold. But you are all in offices where a patient can walk in. What do you do? And you could tell them, go home. Your front desk should already be wearing masks. But here's the guideline, and I believe this is on one of the sites. It might be on the Mount Sinai site or on the Fall Clinical Derm site. Immediately put a mask on the patient, and whoever whisks the patient down should put on a surgical mask and close the door so that other people are not exposed to that patient. Isolate the patient in a room. Whoever's examining that patient should be wearing the maximum amount of personal protective equipment, eye protection, surgical mask, a contact isolation gown, and gloves. Don't expose yourself to COVID-19. And, last but not least, assuming that the patient is not that sick, then what you would want to do is send the patient home, self-isolate until their symptoms resolved, and I gave you the 3 rules for ending self-isolation. If their symptoms worsen, then they need to call their doctor, and they may need to be seen in one of the COVID-19 centers. Now, here are the individuals who you should be testing. Patients who have moderate to severe symptoms, patients, and so if somebody has an advanced flu-like illness, really severe, debilitating fatigue and myalgias, high fevers, those are the patients you should bring in. Anyone who's short of breath needs to be brought in. Somebody with high risk for complications, that includes diabetes, emphysema, asthma, heart disease, or patients who are immune suppressed. Anyone who is at risk for group transmission. So if they live in a shelter with a lot of other people, or if they live with immunocompromised individuals or elderly individuals, you can consider them for testing. All pregnant women should be tested, and anyone over the age of 65, according to this guideline, should be tested. But I will say we actually do not have enough tests for that to occur in New York City. Now, if someone didn't get tested, but you think they might have had it, here's a script which is available on those websites I mentioned. Although you're not tested, it's still possible that you have COVID-19 or another respiratory infection like the flu. Most people are mildly ill with COVID-19 and can recover at home. And then the traditional things you do are what you do for the flu. Fluids, medicines for fevers, cough, and other cold symptoms. Self-isolation is very important. We don't have a Tamiflu yet for COVID-19. And again, I want to repeat the 3 things you look for are no fever for 3 days, respiratory symptoms are improving, is the second of the 3, and the third is at least 7 days have passed since your illness has started. Okay, here's a question. How long does COVID-19 last on surfaces? And here's the answer. If somebody sneezes, it could hang out in the air for 3 hours. On copper, it lasts 4 hours, plastic 72 hours, cardboard 24 hours, stainless steel 48 hours. So copper is the winner here. Because it can last on household surfaces, when you, if you have COVID-19 or if you suspect you might, avoid sharing personal household items. That includes dishware, glasses, cups, eating utensils, towels, or bedding. And if you use those, they have to be washed with soap and water. You can clean high-touch surface areas, cell phones, keyboards on computers, tabletops, doorknobs, bathroom phones, bathroom fixtures, anything that you see on this list, anything you touch a lot, you can disinfect with alcohol. You can use a spray, you can use a wipe, but those should be cleaned every day. Don't forget about the hand washing guidelines. When you wash with soap and water, 20 seconds. Anything, a hand sanitizer that contains 60% alcohol. I was asked a question, which I didn't put in our questions. If a patient has palmoplantar psoriasis and the hand cracks, and now you're drying it up with soap and water or with alcohol, which really stings in our psoriasis patients, what do you do? Well, unfortunately, we don't have any good non-irritating disinfectants. And all I can say is after you wash your hands, put a hand cream on, moisturize well. There are some alcohol-based sanitizers that are very mild. There's one that I have on my desk called Avogard. Got it right here. By the way, I don't have any conflicts of interest with 3M, but we have one in every examining room. And I, by the way, have been doing that for years, not just because of COVID-19. That one happens to be 61% alcohol. It actually feels pretty good. Avoid touching your eyes, nose, and mouth with unwashed hands. If you blow your nose, throw your tissues in a lined trash can and immediately wash your hands so you don't spread the virus further if you are shedding the virus. Okay, now to some drug-specific questions. I'm on Ilumya. My psoriasis has been clear since 3 weeks after my first shot. I'm due for my third injection next week, should I get it. I don't want to come to the office. So here is a dilemma which has several possible answers. The patient is clear. One of the nicest things about Ilumya, it has one of the longest durations of remissions of any of the treatments we use. Here they used 50% loss of response as their endpoint. And if you look at that, in patients on the 100 milligram dose, at week 64, only 54% had recurred. So you're going over a year without a recurrence. Certainly there's no rush to get the next shot. Second possibility is come in and get the shot. We consider 23 blockers as a group to be safe, and there's no reason you have to stop it. Another point I didn't make, by the way, is that Ilumya specifically, and I have the poster here. If you look for how, when you stop it and then patients recur, and then you retreat them, what proportion recapture their response? And I showed you some data last week on many of the other drugs. This is the Ilumya data. 96% regain their response in less than 12 weeks, 49 out of 51 patients. So very high recapture response rate with Ilumya, also very long duration of remission. So there's several possibilities here. One is come in for your treatment. Two is put it off until your psoriasis recurs or until you're comfortable coming in. But there's a third option that which we did look at. And actually, I saw a patient by Telederm yesterday who didn't want to come in. And we looked into the possibility of sending her injection to her. You can either deliver it to her, and incidentally, Ilumya lasts longer than any other drug we have if you leave it out of the refrigerator. It lasts for 30 days out of the refrigerator. So it could be delivered by someone else to that patient. You could send a visiting nurse in to give it to that patient. And we called Briova and BioScript, which is another pharmacy benefit manager, and they have said that they will allow us to ship these injectable drugs, which normally are part of the patient's medical benefit. They'll allow us to ship them to the patient and still consider it a medical benefit. There's a big difference, and if you have a Medicare patient who you prescribe a drug that's given in the office, it's completely paid for by their medical benefit. If you give them one that's covered by their pharmacy benefit, let's say it's Medicare Part D, there's a donut hole, which is somewhere up to $5,000, and then they're responsible for 5% of the cost. For some of our drugs, that would be 5% would be $4,000 a year. For Ilumya, it's about half that. But the bottom line is many of our patients can't afford those thousands of dollars. So if we can get the pharmacy benefit manager to allow us to ship the drug to them and consider it a medical benefit, then the patient won't have to pay anything. That is really a blessing for our patients. And I think that a lot of the pharmacy benefits, we're kind of always at war with them. Like everyone else, they are pulling together and saying, let's do what's best for patients. And I think that that's been happening. So that is a possibility too. Okay, then this is a question that stems from some of the comments I made last week, where I pointed out that Stelara, there's been no increase in infections, specifically viral infections, but it does block IL-12 and IL-23, and IL-12 plays a role in viral infections. So wouldn't it be wise to switch those patients to drugs that block IL-23 alone and actually work better? And I will say that in my practice, I have been trying to do that. Well, I actually contacted the company that makes Stelara, and I'll show you the data they sent me. But this is a slide I showed last week, which is published. And if you look at the rate of serious infections for 100 patient years, ustekinumab has fewer serious infections than any of the TNF blockers, any of the other biologics looked at, and even the patients not treated with methotrexate or a biologic, it has fewer infections. So it appears to be quite safe in the setting of viral infections, and that was confirmed by the information that I got from Janssen, and I'm trying to uncover this here. Yeah, if you look over on the right-hand side of the slide in yellow, you look at the frequency of infections and infestations. The second to last column is the placebo group. The last column is the ustekinumab group. And you see there are more infections and infestations per 100 patient years in the placebo group. And if you look at influenza-like illness, there are many more cases of that in the placebo group compared to the ustekinumab group. And this data comes from phase 2 and 3 studies. If you then look at the SOLAR registry, which I've said already, but not looking just at serious infections, but at influenza-like illness, the numbers for Stelara compared to any of the other groups is on the low end. So certainly lower than any other biologics. So switching, and again, the SOLAR registry was at a time when we pretty much were comparing to TNF blockers. We did not have IL-17 or IL-23 blockers. And, you know, the bottom line here is that Stelara does appear to be a fairly safe drug. Having said that, IL-23s work better. Okay, I am clear on Cosentyx, Talx, or Siliq. So this was an IL-17 patient writing in, and I added all the drug names. Do I have to stop because of COVID-19 exposure? You know, we said this already. We showed you the guideline from the NPF and from the AAD. If patient has an active infection, they should be stopped. If they don't have an active infection, we do not discontinue biologics. And we actually know a lot about the IL-17s. There are patients born with deficiencies of IL-17. They don't get more viral infections. They get chronic mucocutaneous candidiasis. Mice in whom you knock out IL-17 don't get more viral infections. They get chronic mucocutaneous candidiasis. So that's IL-17 is blocked by Talx and Cosentyx. Siliq blocks the receptor. Well, it turns out that there are individuals who have mutations in the receptor for IL-17, and guess what? They don't get more viral infections. They get chronic mucocutaneous candidiasis. So it appears like the 17s should be safe. Again, coronavirus is new. We don't know a lot about it. We could be speculating here, but at least we're looking at some evidence based on clinical trials in the past and also animal models or even human models in the case of the IL-17s. Now, here's another patient on TNF blocker. Does this patient have to stop the TNF blocker because of COVID-19? And the answer is we have been trying to move our patients from TNF blockers to the 17 and 23 blockers simply because they are safer and more effective. And we have been doing that actually for years, even before coronavirus came out. But there are individual cases where the patient is doing well, and why would you stop them? And I showed this case last week. So it's a woman of childbearing potential. She's 28 years old, so she's very low risk. She's on Cimzia, doing great, and she's very comfortable on Cimzia. And when we mentioned, why don't you switch to a 17 blocker? And a 17 blocker would be a good choice here. She does not want to switch because Cimzia doesn't cross the placenta. All of the other biologics do. So there are two good options for this patient. IL-17s would be a good choice, but she's not high risk, so you can stay on the Cimzia, and she elected to do that. Okay, here's another one. My patients are afraid to come in. Can I see them by teledermatology and get reimbursed? This is a really important question. Our census is down by 90%. We are seeing very few patients in the office. Yesterday, we did our first teledermatology. Let me tell you all, it's easier than seeing a patient in person. The government has now passed regulations that, at least for Medicare, those visits are reimbursed at the same rates. And as for people with private insurance, what we're doing is we're saying we're going to try to bill your insurer, but we're taking your credit card because if we're not getting paid, we're just billing $100. my schedule's full with those patients. So I would encourage you all to look at teledermatology as an option. The government has been very responsive here. They have waived HIPAA requirements, so you can use Facebook or Skype. So there's, because those are not HIPAA compliant. And they're making sure that we get reimbursed by Medicare. So I'm going to close with a little bit of humor. Remember social distancing. And I do want to also close by introducing Stacy Bell, who's the medical director of the National Psoriasis Foundation, who's going to say a few words. And let me say the Psoriasis Foundation has been at the forefront of our being able to deal with this crisis in our patients on biologics. They came out with their position paper this week. They have been moving very quickly to make sure our patients have access to therapies, and this is one of the best organizations in dermatology. So with that, let me introduce you to Stacy Bell, who is a superstar at the foundation. Stacy.
Thank you for the very informative webinar, Dr. Lebwohl. Your perspectives and guidance are so valuable to our community, especially during this uncertain time. My name is Dr. Stacy Bell, and I serve as the Chief Scientific and Medical Officer for the National Psoriasis Foundation. The NPF continues to support our patients and their families, along with our healthcare providers and researchers during the COVID-19 pandemic, and we're adding new approaches to do so. As Dr. Lebwohl noted, our medical board issued recommendations for our community in relation to COVID-19 this past weekend. Our medical board, scientific advisory committee, and our team continue to monitor the situation closely. The NPF is being very proactive about up-to-date COVID-19 resources for both our patients and providers. Check out the podcast coming out this week. Our Patient Navigation Center is here to help, and we continue to offer dynamic educational offerings. Many of our advocacy efforts, Team NPF events, and programs are going virtual. Check out our website. Thank you for your time, and I look forward to partnering with you through this crisis, and most importantly, supporting each other on a day-to-day basis. Thank you very much.
Well, thank you very much, Stacy. And even in these troubling times, let's not forget the Psoriasis Foundation, www.psoriasis.org. Now, we've had 100 questions at least sent in already, so I'd like to get to them right away because we have the limited time this evening. Here's the first question, Mark. I have a hidradenitis patient doing very well on Humira. Do I have to stop it?
So we have not been stopping Humira in patients with hidradenitis. It's the only drug we have approved, and if you stop it and then restart it, there's a good chance you'll end up developing antibodies to it and it'll stop working. So we've not been holding Humira in those patients.
Okay, our next question is, my patient has the worst case of atopic dermatitis I've ever seen. She's almost 100% clear on Dupixent. Is it smart to stop it and wait a few weeks for this, I assume, COVID time to be over?
So, I actually think that would be a mistake for several reasons. First of all, Dupixent is not an immunosuppressive drug. In fact, even the package insert never uses the word immunosuppressive. It calls it an immunotherapy. And actually, the word immunosuppressive and the word viral do not appear in the package insert. It's not associated with an increase in viral infections. When you look at patients treated with Dupixent, we're taking patients with very elevated interleukin-4, and we lower it to normal, at least in the skin and on skin biopsies. We don't lower it below normal. We lower it to normal. So, it's not immunosuppressive, but the most important reason is it's a treatment that is effective for asthma. Many of our atopic dermatitis patients have mild asthma, and that would be a risk factor for getting severe COVID-19 pneumonia. And so why would you stop the drug that is preventing that? I think that would be a mistake.
Okay, our next question is, can we postpone gamma TB interferon yearly testing if the patient's on a biologic during this pandemic? She has a patient be tough to bring into the hospital.
Yeah, honestly, the biologics are quite safe. And the monitoring, it's not like monitoring for cyclosporin or methotrexate where you could really get in trouble. If you delay it for a few months, there's no big issue. So, the answer is wait until this pandemic is over and then check the patient's TB test or any other labs you want to test. These drugs are pretty safe compared to what we've used in the past.
Okay, our next question. My patient's on light therapy, and I'd like to know if the immunosuppression from phototherapy may make them more susceptible to coronavirus infections.
Light therapy is hardly immunosuppressive. It's never been associated with, opportunistic infections. There's a tremendous amount of work done on light therapy in patients with HIV, and it is not associated with a worse outcome. So I don't see any problem with ultraviolet light treatments in patients who have during the current pandemic.
Okay, here's actually two questions that are related. The first question is, are your respective offices currently open? And the second part is, what kind of precautions are you taking if your offices are open? My offices are not open right now, although within our group, we actually have some of the group office open for emergency and, obviously time-sensitive dermatology issues. Mark?
So all routine visits that can be done by telemedicine, we are doing by telemedicine. We're actually calling the patients and saying, let's change this to a telemedicine visit. We are obviously open for emergencies, and we are, somebody has a MRSA abscess, that's urgent. People who might have herpes zoster, you want to treat that. So, so we are open for those visits. But the run-of-the-mill routine visit, we are trying to convert to telederm. In addition, if anyone is coming to the office, we actually call them and ask them if they have any cold symptoms. If they do, then depending on how urgent their visit is, we may end up sending them to a COVID center, which is just a couple of blocks up from us in the Mount Sinai emergency room, or we tell them at the least wear a mask when you come in. We don't want you spreading any virus all over the place. So that's what we do differently.
Yeah, we're actually are using telemedicine also. The problem is, for what I do more of skin cancer, it's tough to do a biopsy by telemedicine, and it's tough to do a full body exam on telemedicine. So that's a challenge we're facing. Okay, next question. Do you have any suggestions for treatment alternatives for patients with severe hidradenitis suppurativa who are on Remicade and episodic prednisone?
So, unfortunately, those are drugs that work well. They are clearly immune suppressive. And they're not approved for hidradenitis. If your patient, I would try to treat this patient with adalimumab, Humira, which is approved. But if the patient's already failed that, or the patient's doing well, I understand the desire to keep the patient on a treatment that's working. Stopping Remicade is associated with a dramatic development of antibodies, something like 38%. So you think twice about stopping that drug. I would try to, as much as possible, isolate that patient, protect them from COVID-19, because that patient is somewhat immune suppressed. While we talk about that, I have to say there have been suggestions that immunosuppression prevents the cytokine storm, inflammation, and pneumonia that kills COVID-19 patients. That is certainly not proven, but there's a lot of speculation about that. I think the answer for your patient is have them self-isolate, quarantine, as much as possible, try to prevent them from being exposed to this.
Okay, our next question. Should asymptomatic patients on a biologic stop their biologic or hold their biologic if they've been exposed to someone who has confirmed COVID-19?
Yeah, the guidelines that have been proposed by the National Psoriasis Foundation and the AAD, and I would say this as well, even though I'm a little hard on the TNF blockers, I think that the guidelines say continue your patient on biologics unless they develop the infection. That means even if they've been exposed to someone, we do not take them off the treatment. Only if they show signs of the infection do we stop it.
Next question. With people not knowing whether their symptoms are COVID without testing, which is sometimes hard to get, would you be supportive of postponing therapy for 2 weeks with any symptoms at all along the mild spectrum, since there may be some variability of initial presenting symptoms?
Yeah. So because we do not test patients with mild symptoms, we do treat them as if they have the infection. We send them home. We have the strict rules that I mentioned about when they can consider themselves not contagious anymore. and we have them, monitor their temperatures. If they develop worse symptoms, then we have them come to the emergency room where they often are hospitalized. So those patients are presumed to have the infection. Let's say that you could test them. There's a high percentage of false negatives. The estimates are as high as 25% is the highest one I've seen of false negatives. So, let's say you have an employee in the office and the employee starts developing a cold and you say, oh, it's just a cold. Well, you don't know that. So I would send that employee home. Everyone else in the office who potentially now has been exposed, we tell to wear a mask and protect everyone else from exposure in case they have indeed acquired the virus. So that's how we deal with that circumstance. And again, the testing is not available easily, and unless you're very sick, and there is a significant false negative rate.
Okay, if we stop a patient's biologic, how many months they need to be off the medication before a loading dose has to be done once they restart the biologic?
So that is entirely up to the insurance company. Let me say, first of all, it's very hard to overdose with any of the biologic therapies we currently use. They are very targeted. So they only block a small part of the immune system. It's not like taking a methotrexate overdose or a cyclosporin overdose where you're going to damage, the bone marrow or the kidneys. When you take, and actually there are a number of patients reported who overdosed on specifically Cosentyx. There's also at least one patient I'm aware of who overdosed a little on Taltz. And basically the Cosentyx story is, it's given 2 injections a week for 5 weeks in a row. Well, there are at least 2 patients I'm aware of, and they're written up, who took 2 shots on Monday, Tuesday, Wednesday, Thursday, and Friday. So they got it 5 days in a row. That's a massive overdose. Guess what? They got better faster. Nothing bad happened. So I wouldn't worry about overdosing. So if a patient's off for a month or 2 months and you want to do a loading dose again, that's fine. The problem is the insurance companies often won't give it to you. If they will, and their psoriasis is back, I would give them, as much as you can get.
Next question, if a patient has failed multiple biologics and is presently on an IL-17 receptor blocker and methotrexate and fairly well controlled, should I hold the methotrexate?
So that's a very tough case because, unfortunately, in psoriatic arthritis, when you hold them, if you just abruptly discontinue methotrexate, often the arthritis comes back, and even badly. So, what we try to do in our practice, and we're not always successful, is we try to lower it as fast as 2.5 milligrams a week. So if somebody's on 15 milligrams, they'll go down to 12.5. The next week, they'll go down to 10. The problem with doing that is they often flare when you're doing it. We can't always get them off.
Many patients who died with COVID-19 were on a biologic, and if so, which biologic?
So I'm aware of one report of a patient on Humira who died, and that's through an email that I received. Now, I'm going to just say, Humira is one of the most commonly used drugs in the world. So having hundreds of thousands of people on the drug and millions of people now affected by, or certainly going to be millions of people affected by COVID-19, you're going to expect that there's going to be one of the deaths is going to be on a patient on Humira. I'm aware of at least one patient on Salik who is doing well with COVID-19. We are now at Mount Sinai trying to accumulate data on patients treated with biologics who are proven positive for COVID-19 and just seeing how they do. The other side of this story, and the one that is feeding the frenzy about immunosuppression might be good, is that I got an email this morning from an Italian dermatologist where they've had tens of thousands of cases of COVID-19, yet only 40 transplant patients have been diagnosed with the infection. So, the suggestion, of course, there is, well, maybe the transplant medicines are suppressing the immune response. You don't get the pneumonia. But that really is speculation. We really don't know yet. At the end of this, we are going to find that out. There are a lot of people looking at it, including us at Mount Sinai.
Okay, this is sort of a combination of 2 questions. How prevalent are asymptomatic carriers, and what is the rate of false negatives?
So I answered the rate of false negatives, but it has a lot to do with the false carrier rate now. When about a week ago, when we looked at the numbers of people who showed up in our emergency room to be tested, only about 1 in 10 was coming out positive, which meant that, many of them were just showing up because they were worried. Maybe they had a cold, maybe they had hay fever, but probably some of them were false negatives. And I can tell you that there have been patients who were hospitalized, very ill, were false negative, and then proven to be positive. So we know that false negatives occur. We believe that there are many, many asymptomatic carriers out there. So when you hear the numbers about the death rate from COVID-19, in China it was reported as high as 2%, even 4%. The number's not that high. There are a lot of people out there who simply never show up to the ER because they're not sick. And that's what we're missing. We don't have a precise number, though.
Okay, we're getting sort of short on time, but there are two more questions that are important. One is, we've had a number of people ask, can you make these slides available on demand?
So these will be posted at fallclinical.health tomorrow. There will also be some useful information about COVID-19. There are some other very good sources. The CDC is a very good source. The World Health Organization is an okay source. The National Psoriasis Foundation is a very good source. If you Google Mount Sinai coronavirus or COVID-19, Mount Sinai has a website that comes up for healthcare professionals, which gives a lot of this information. There are a number of good sites. Fallclinical.health tomorrow will have these slides.
And I have to finish with this last question because I couldn't leave it out. This is clearly one of your big fans, Mark. They say that you look great in a shirt and tie, but you've been sitting through the whole time of this presentation. Are you wearing pants? I swear this came in.
Great question. Yes, I'm wearing pajama pants.
All right. Well, with that, this closes our session. We hope you've gained useful practice knowledge. I'd like to again thank Lilly, Ortho-Dermatologics, UCB, Sun, Sanofi Regeneron, Novartis, and AbbVie for their continued support of dermatologic education. And also thank the National Psoriasis Foundation. Don't forget psoriasis.org for their collaboration. We're going to be archiving this presentation on our site, as Mark mentioned, fallclinical.health. So if your colleagues could join us today, they should be able to see this on demand starting tomorrow afternoon. Next week, we're going to begin our Fall Clinical Virtual Grand Round Series. And this will be an 8-week, 1-hour CME program with updates on key issues facing us presented by recognized experts in the field, followed by a therapeutic session. You're going to be able to hear from our top Fall Clinical faculty while they present the newest knowledge that you really need to know, including practical tips and pearls you can apply into your practice. This program will be provided to you at no cost. Next week's session will cover enhancing the rapid integration of telemedicine into your practice and also managing your acne patients during COVID-19. Please look for the email invitation for full details and times. On behalf of Mark, myself, and all of the Fall Clinical course directors, I want to thank all 2,000 of you who registered for a course tonight for joining us. Please stay safe and stay well. Thank you very much, and see you next week.